Okay, regarding your published article, Metabolism and Cancer Select Topics, you discuss the notion that cancer incidence is directly linked with metabolic rates across animal species. Is there any evidence that in humans are conditions with increased metabolic rate, such as hyperthyroidism, also are burdened with increased cancer incidence?
Certainly there is. First, I wanted to make the point that the association between metabolic rate and cancer incident has been independently verified in a large European study of around 450,000 people. As I mentioned in my paper, this paper was quite significant in terms of number of people accrued and in terms of follow-up, which was 14 years. And this paper pretty conclusively demonstrated that the high basic metabolic rate translates into a higher incidence of cancer. Therefore, again, confirming that the association, the seminal observation made in animal species by Klebert is also valid for humans. Now, more fittingly and more to the point, to answer your question specifically about the incidence of cancer in patients like hyperthyroidism patient that have been known for a long time to suffer of increased basic metabolic rate. That association has also been proven in many studies. For instance, there is a study with 72,000, there's a Chinese study with 72,000 individuals, and they showed that there is an association between hyperthyroidism and increased incidence of cancer, and also the opposite is true, that hypothyroidism translates into a reduced incidence of cancer. For instance, the association with breast cancer was the odds ratio for increased free thyroxine with increased breast cancer was of 1.07, the odds hazard ratio. Therefore, whereas the association between hypothyroidism with breast cancer was 0.94. So again, hypothyroidism translates into a reduced incidence of cancer, for instance, breast, and hyperthyroidism in the opposite. The association between hyperthyroidism and increased cancer incidence has been translated also, has been verified also in other cancers, such as prostate, ovarian, gastroesophageal, pancreatic, colorectal, and of course also with the thyroid cancer itself. Now, I think that from the molecular standpoint, an interesting observation to make is that the effects of thyroid hormones are both on the metabolism, particularly in the mitochondria, thyroid hormones increase number of mitochondria, they increase the oxidative phosphorylation process. And on the other hand, it has also been shown at the molecular level that thyroid hormones have the ability to induce a series of to stimulate a series of pathways that are important in carcinogenesis. So we have an example, which again, I think we'll see also in other instances, and maybe we can talk about it later on when we will discuss NAFLD and cancer. There is at the molecular level, I think it's been demonstrated that the two processes of metabolism and cancer are really oftentimes stimulated in a synergistic and in a synchronous fashion, again, proving at the cellular and at the molecular level that the two processes are intimately connected.
Thank you. You also report in your paper that obesity is a major risk factor for incident cancer. Is this reversible, Are you aware of any intervention studies supporting the logical expectation that by treating obesity, a reduction in cancer incidence will ensue?
Yes, there are several studies proving that. I would like to quote the largest studies present so far, and the first one is a Swedish study that accrued 4,000 patients, including 2,000 controls and 2,000 cases. And they showed that, and these studies showed the association specifically between bariatric surgery and cancer incidence. This first study proves that, again, 4,000 people with a follow-up of about 11 years, and this study shows that the odds ratio adjusted for sex, age, and other risk factors is 0.71 for treated patients. So again, shows that undergoing bariatric surgery does reduce the risk of cancer. A confirmation of this finding has been published not later than last month, on June 3rd, in JAMA. And this is an American study from Ohio. And this is a huge study including 30,000 patients. These 30,000 patients, 5,000 were actually cases, and 25,000 were control non-surgically treated patients, and the follow-up was 6.1 years. So the estimated incidence of 13 types of obesity-associated cancers at 10 years was reduced with an adjusted odds ratio of 0.5. So you're pretty much halving your risk of cancer. So it seems that, you know, these data do show that the increased risk conferred by obesity does translate, is actually reversible, and actually can be combated by appropriate intervention to reduce the fat, to burn down fat. However, it's also important, as Sirico et al. Mentioned in their paper appearing in Childhood Obesity in 2018, that up to 30% of obese people may show normal cardioprotective traits, for instance, serum lipids and glucose levels. So they are obese, but they, in terms of their serum profile, they are okay. And yet these patients are also a risk for obesity related complication. Again, this makes the point that obesity per se, that increased fat, actually does translate in increased risk, even in a clinical scenario where you would not expect that to happen. So obesity seems to be actually an independent risk factor for these patients. It's also true that people of normal weight may be metabolically similar to obese patients. So the comparison cuts both ways. And in particular, also it's important that to make the point that people that may have a normal profile and may have normal weight, but they may have increased visceral fat. And this idea that visceral fat, the idea that the distribution, the anatomical distribution of fat is actually as important, if not more important, than the overall weight, I think is a very, very important one that comes out over and over from these studies. So basically, not all fat was created equal. There are many studies to support that contention. For instance, the studies on prostate and lung cancer. So if you take those studies at face value, obesity seems to reduce the incidence of prostate cancer and to reduce the incidence of lung cancer. However, if you adjust for visceral fat content, then the situation changes dramatically, and people that do have increased visceral fat actually have an increased incidence of exactly that those types of cancer. They are more aggressive. in this regards to prostate cancer. As you know, the majority of prostate cancer are clinically indolent. You know, it's a very indolent disease, and I always tell medical students that the patients are more likely to die with it than of it. So these are important considerations to make. Again, not all fat is created equal, was created equal. Another important point to make is that cancer is a multifactorial event, and you have also many other conditions that may modulate the risk of developing cancer or the risk of having a more aggressive kind of cancer. And not only obesity per se, or let's say, an increased adipose tissue content is important, but also diet is important, physical exercise are important. So you cannot really isolate one factor, say increased BMI or increased visceral fat. But also you have to consider that, again, since the human organism is very complex and the pathogenesis of cancer is quite complex, all these factors actually do have an interplay, again, visceral fat content, overall fat, as reflected by BMI, but also diet, physical exercise. These are all factors that come together in determining your actual risk of cancer. So in terms of, if you want to translate that into a clinical scenario, I think it's important as a clinician also to tell our patients that they should not just pay attention to the weight per se, but they should also strive to lead a balanced life where where people do not live a sedentary lifestyle. People do have healthy eating habits. These are all very important factors.
Thank you very much, Fulvio. Clearly, taken collectively, these studies that support that cancer may develop in association with metabolic disorders, in a sense, represents a paradigm shift from exogenous cancerogenic stimuli that were mostly emphasized when we used to be medical students. Some of these examples could be, for example, cigarette smoking and lung cancer, chronic liver disease owing to chronic viral infection, or alcohol misuse in relation with liver cancer, infection with papillomavirus and uterine cervix cancer. Do you believe that this cancer paradigm shift is going to dominate the epidemiological scenario for the forthcoming years, owing to population becoming older and older, and as you mentioned before, people leading unhealthy lifestyle habits?
Absolutely, that is a crucial take-home message. And as you said, compared with what we learn in medical school, it constitutes a major paradigm shift. On the other hand, I also would like to stress again that cancer is indeed a multifactorial phenomenon. And if you look carefully and tightly, even at situations where the contribution of the environment seems to be overwhelming, and the obvious examples are the ones you mentioned, HPV and cervical cancer, smoking and lung cancer. Well, if you look carefully at those types of cancer, you will also see that there is actually more than meets the eye. There is more than just the type of papillomavirus, low versus high risk, and there is more than the amount of smoking. For instance, only a subset, only about 10% of the heavy smokers develop lung cancer. So again, why is there a difference, or why some people smoke end up dying of complications of atherosclerosis, MI and the likes, and others end up developing one of the many cancer, and some other patients end up dying of one of the many cancers which are associated with smoker, i.e. Bladder or lung. It's not really known, but if there is one thing that we have learned from recent developments in oncology is that there is no such a thing as a cancer, but there is a single cancer patient. So each cancer patient, so for instance, the mutational profile of lung cancer is incredibly varied. And again, this only recently, this is becoming appreciated, so that, for instance, patients who develop lung cancer without smoking have a different mutational profile of patients who develop lung cancer in the setting of heavy smoking. So again, every patient is different. Now, why exactly some people, if you take again 100 smokers, why only 10 will develop lung cancer? Again, it's not known, but that does make the point, and that's my take-home message, that again, cancer is actually a multifactorial agent, but you're absolutely right. We have becoming more and more aware of this phenomenon, and in particularly, we have learned, and this I think constitutes a major advance in recent oncology, actually in medicine overall, that metabolism actually, disturbances in the metabolic processes may indeed constitute one significant modulating factor, and they may determine whether a patient with a certain risk factor will die of the specific cancer or not.
And the risk factor in many cases is genetics, although this is difficult to be proven in the individual case out of the research field. As a clinician with a long expertise in internal medicine and hepatology, when I think of obesity, I always think of the role of the so-called fatty liver syndromes. You may call it NAFLD or muffled more recently. So what do you think these two fatty liver syndromes, how they can interact, if they can interact with the process leading from obesity to cancer, for example, in particular with colorectal cancer that you mentioned in your paper?
Yeah, that's a very important question, and actually, you actually have addressed very effectively the problem in your recent review as an editorial on the paper of Allen, basically NAFLD is pretty much at the crossroads, and but it seems that not only is guilty by association with insulin resistance and with obesity, but also there may be something very specific about in NAFLD and certain types of cancer, and particularly, again, as you mentioned, you wrote an editorial about it, particularly colon cancer. Now, there is obviously a tremendous amount of research to find out, again, to what extent there is a specificity of this interaction, to which extent NAFLD preferentially increases the risk for colon cancer versus others. This is a novel and fascinating field that obviously we're expecting to, we're hoping that, and we'll come to the end of it and we'll try to understand why it is. But so I don't have for colon cancer a specific explanation, and again, all I can do is refer to actually your nice scheme, your diagram, where you included as possible mechanisms linking NAFLD to colon cancer several factors, including the establishment of a pro-inflammatory state, the presence of insulin resistance, the abnormal production of adipokines, liver fibrosis, and last but not least, local factors such as the disturbed bile acid production. And that, I think, is very interesting because, again, establishes a specific link, a specific anatomical link between NAFLD and colon cancer. Obviously, the bile acids, which also in the past have been that they've been proposed to possibly be a pathogenetic factor in colon cancer. But again, that establishes a direct anatomical link. So, so again, these are scenarios that need to be investigated further. And the only other mention I would make is that of a recent paper that talks about the association between liver cancer. Obviously, an AFLD not only increases incidence of obesity-related cancers, including colon cancer, but also of liver cancer itself. And then there's a fascinating paper published in December 2021 that, and this is a paper based on animal models, using transgenic animals. And basically the conclusion of this paper is that there is a key molecule, there's a molecule that links the development of fatty liver disease and the presence of, and the activation of carcinogenic pathways within the liver. This molecule is spectrin, which was shown to be crucial, to be really at the crossroad and being able, and so this is the classic definition of a pleiotropic gene, a gene that has multiple and varied function. And again, this is surprising and fascinating at the same time, because I don't think anybody in our times, when we were students, I'd say, but even more recently, would have thought that the link between metabolism and cancer was so tight to the point that, again, same molecules end up being able to control both pathways. Fascinating, the discovery.
Yep. Thank you.
You're welcome. Thank you.
Bye.